Warm greetings to one and all. Let's wait for a couple of minutes while we admit the rest of them. Hope you all can hear my voice clearly. So once again, this is Dr. Anita Sarjan, your MC for the session. If you wish to claim your certificate for the same, kindly visit our website, which is www.onlinedentistry.in/9 p.m. and register for the same. Online dentistry has been the pioneers in providing dental education via both online and offline platforms. The motto we preach is to redefine dental education. It has been over 14 years that online dentistry have been conducting sessions for clinical practitioners across the globe. Established in the year 2008, so far we have covered over 203 offline courses and have conducted 1,022 online courses with an enormous amount of more than 30,000 followers on our platform. Let me proudly introduce the CEO of online dentistry, Dr. Binuji Abraham, who's one of the finest practitioners in town, an orthodontist by profession, a passionate photographer, and he owns his private practice at Kerala Dental Clinic, Alabay. Moving on to the academic head of online dentistry, Professor Dr. Joby Peter. He's currently the HOD of Department of Pediatric Dentistry at Annu Dental College, who preaches the philosophy to catch them young and watch them grow. Over the years, we have grown dynamically, launching 10 centers in different parts of India. On popular demand, we are launching our next 3-day session on November 24th, 25th, and 26th at Cochin. We are open for fresh registrations via our website. The latest addition to our courses, the 1-year comprehensive and advanced master training series on indeceptive and myofunctional orthodontics have been successfully initiated with 2 batches. So basically, this is a multidisciplinary approach with intense training and hands-on session. Our program is now a fellowship program on indeceptive and myofunctional orthodontics, which is accredited by the Manipal University College, Malaysia, which is a sister concern of Mahi University. Herein, 2 of the modules will be happening in Malaysia, along with a graduation ceremony and a certificate distribution as well. We are a batch full now, but due to overwhelming response, we are expanding our batch this time. So 2 more seats are remaining. You all can feel free to reach to us on our WhatsApp number or visit our website, which is www.onlinedentistry.in, or else you can mail us on onlinedentistry.in@gmail.com. Online dentistry have been conducting sessions all over India for the past 14 years. So during the lockdown, we started conducting online sessions to benefit the practitioners, which was received with great appreciation from the dental fraternity. In the year 2023, we are relaunching the same under the title Online Dentistry at 9 p.m. So, without further ado, let me move on to introducing the speaker for the day, Dr. Vijit Narayana. He secured both his BDS and MDS in conservative dentistry and endodontics from GDC Trivandrum. He has also undergone clinical training in implantology. He is a member of Conservative and Endodontic Society of Kerala, Indian Association of Conservative Dentistry and Endodontics, and also Academy of Cosmetic Dentistry, India. He runs his practice at Cochin, focusing on microscopic enhanced endodontics and aesthetic dentistry, along with his wife, Dr. Kavita Kumar, who's a periodontist as well. He has also been the key opinion leader of Dentistry Saronia, and currently he is a key opinion leader of Colton Walden. He has lectured and conducted training programs on endodontics, aesthetic dentistry, magnification, rubidimology, and photography on various platforms like IDA, dental colleges, and also at his own academy at Cochin. So proudly welcoming the Sir of session. Sir, the session is all yours.
Thank you, Dr. Anita. Let me just share my screen. Yeah, so I hope I'm audible and the screen is visible. Can I have a feedback, please? Dr. Anita?
Yes, sir. Yes, you are visible, sir, and your slides are also visible, sir. Go ahead.
Yeah, good. So I can see the number of participants are going on increasing now. It's 52. Hopefully within a couple of minutes, we'll be going ahead with the full strength. So the topic for today's presentation is damn it or be damned. I'm going to talk about the importance or the significance of using rubber dam in your practice. And I hope that most of you who are here to learn the technique of rubber dam. Maybe you have used rubber dam and not able to do it properly, or maybe you are planning to use rubber dam, planning to learn rubber dam to upgrade your dentistry. And if so, this is the best thing to start off. If you are planning to upgrade your practice of dentistry, trying to put rubber dam or starting with the practice of rubber dam isolation is the way ahead. Okay, so before I start the program, I thank Dr. Joby Peter and Dr. Binu Abraham for inviting me here for this presentation. Well, go ahead. So the topic is damn it or be damned. So before I start, I had a beautiful introduction from Dr. Anita, but just to tell you that you can follow me on my Instagram page, Dr. Vijit _dentistry. And also I have an academy where I conduct courses on endodontics, restorative dentistry, rubber damology, aesthetic dentistry, and dental photography. That's what I do 80% of my time, and the rest of the 20% of the time I spend with birds and humans clicking their pictures. So this is my passion and other is my profession. Okay, right. So why isolation? Why do you think we need isolation? To explain to you why we need isolation, there is no better picture than this. What you see here is a crowd. What you see here is a crowd, and the crowd is so non-specific. It's very difficult for you to choose a single person from them. But as soon as I cover rest of the people, rest of the crowd, what you can see is a single person is isolated. So this is exactly what rubber dam isolation, or this is exactly what isolation does to your working area or your operating field. Okay, what is the importance of isolation? Basically, it gives moisture control. All these things are not new to you, so I'll just rush through all these things so that we come to the good part of our presentation. Okay, the importance of isolation is that it gives good moisture control, helps in tissue retraction, and gains access. So most of the time the tissue just doesn't mean the gingival tissue or the cheek. The tongue also is a part of the tissue which interferes with your access to the area. So rubber dam, what it does is it simply keeps the other tissues away so that your tissue of interest, that is your tooth, is in focus. Okay, now harm prevention. We know that our instruments or small endodontic instruments can cause harm to the patient if the patient aspirates or swallows it. So such things can be avoided by simply by using rubber dam. Improved operator efficiency, just because rest of the things are away from our purview, it's very easy and it's very simple for the operator to just concentrate on his job at hand. Okay, so it improves the operator efficiency. Now moisture control, what is the advantage of moisture control? That it gives dry, clean operating field. We know that when the operating field is dry and clean, it improves the properties of the materials that we are using, the mechanical properties of the materials that we are using. If the material gets contaminated by the moisture or the saliva, the mechanical properties gets deteriorated with time. So that is one very big advantage. And most important is the part that if the dentine gets contaminated by saliva, there are umpteen number of studies which show that if the dentine gets contaminated by saliva, the bond strength of the dentine decreases many times. So that also is probably that is the most important reason why we should be using moisture control or rubber dam isolation for restorative dentistry. Now, there are various means of isolation, which the most common of them is cotton roll. it can be considered as a quick way of isolation, but it doesn't give, or it does not provide you with proper isolation, proper restorative practice. Now, the other technique where we use, the other technique by which we can get isolation is by retraction cord, where we help the gingival tissue to retract, and that can also give us some amount of isolation. Again, not a very ideal way of isolating the tissue. Another very common or a very popular technique is again to use Teflon tape, which can also help in gingival tissue retraction. Again, as I said, it's not a very ideal way of isolation, but again, it can help you with a quick restorative procedure. Probably you can use it, but it's like in this case where this is the distal part of the last molar that is in the mouth. So again, very difficult to isolate. So tissue retraction using Teflon tape can help help a lot in getting or isolating the operating field. Okay, now coming to our topic of interest today, rubber dam. So why rubber dam? Just because I do not want to be like this in my practice. I have only 2 hands and I have to control or have to operate in the area of interest with those 2 hands. I don't have 6 more hands like a spider, where the spider has 8 hands and all the 8 hands are functioning. For my purpose, I have only 2 hands, and I do not want to be like a spider where once I'm trying to manipulate the material, I'm trying to fix the material, I'm trying to fix the tooth. On the other hand, with the other hand, I'm trying to adjust the tongue or retract the tissue, retract the cheek, or to adjust the cotton roll. I don't want to do such things. And that is exactly why I am trying to use, or I am always trying to use rubber dam in my restorative practice. So that is one of the reasons. Now, another reason is that it relieves a lot of stress. Rubber dam relieves a lot of stress. See, for example, the picture on the left that you can see here, this is a 3rd molar. And the patient was referred to me because the referring dentist could not manage the patient's tongue. You can see that in spite of using heavy rubber dam sheet, here the tongue is protruding so much, or the pressure of the tongue is so much on the clamp itself. You can see that very clearly. So that was the difficulty that the referring dentist faced, that she could not manage the tongue of the patient. So simply by putting a rubber dam here, that 3rd molar, which and the patient was quite a bulky patient with a bulky cheek, the 3rd molar became very easily accessible. So I could easily go ahead with the root canal treatment of the 3rd and the 1st molar. So similar case is what you can see on the next picture also. So basically what it does is you are not bothered about anything else when the rubber dam is on. You're not bothered about the tongue or the cheek or the saliva or anything. So it just helps ease a lot of stress. Then again, for quadrant dentistry, we rely a lot on rubber dam. Why? Because with single isolation, if the patient gives permission to get all the treatments done in that quadrant, it's a very simple and a very effective way, because you don't have to go on changing the cotton rolls, or you don't have to go on sucking the saliva and the water from inside. You can simply go ahead by isolating the complete area and go ahead with the restorations one after the other. And the patient is very comfortable, because for long procedures, we keep a bite block also in the patient's mouth. So that goes a long way in helping the patient to sit for long dental procedures. Now, another reason why we use rubber dam is for tissue retraction. So here you can see a case where it's an old failing composite restoration which was used to fill the to close the diastema. So what in this case, what we did was we removed the old restoration completely and isolated the tooth. What you can see here is that rubber dam has pulled the gingival tissue apically, so that now you can have a proper space for your restoration. And what it does is, when such a kind of such a restoration happens, your restoration starts right at the level of cement to enamel junction. So what it does is it gives a really good eruption pattern for the tooth. So this is the immediate post-op that you can see here. You can see that immediately after the restoration, the gingiva has come down, but it has not completely closed the black triangle or the space that is between the gingiva and the teeth. But within 1 week, you can see that the entire space has been closed. So that is the beauty of compressing the gingival tissue, and it gives you a really good, it gives you a natural eruption pattern. So that is the beauty of using rubber dam for tissue retraction. Very similar case here. This was a post-orthodontic black triangle which the patient wanted to close. So again, a rubber dam was placed and the tissue was retracted. And you can see that without rubber dam, such a restoration is not possible. That black triangle will still see through in such cases if you don't use a rubber dam. So that is the beauty of using rubber dam here. Now, another very simple and not a very simple case, but very important area of application of rubber dam here is, you can see there is a subgingival caries here at the cervical region of lower right first premolar. So the first thing that we did was we did gingivectomy. We exposed the caries completely so that all the subgingival margin became supragingival. So the next after this, what we did was we isolated the we applied rubber dam, we isolated the entire area, and then using a retraction clamp, which I'll discuss within a few minutes now. We're using a retraction clamp, we retracted the gingiva, or we retract the rubber dam completely, so that now our tooth is the area of interest is completely isolated and ready for restoration. So this is after the caries removal, and this is after the restoration, immediately after the restoration, and this is within 3 days of post-operative. This picture shows that the patient had to fly back. So I took the post-op picture in 3 days. Within 3 days, you can see so much of healing, which means that within 1 week, it will be perfectly normal and the tooth is good to go, right? So this is the beauty of using rubber dam. I'm just touching the clinically relevant parts of using the rubber dam. There are so many other advantages of using rubber dam. Okay. So we have certain misconceptions. As someone told that it's not difficult to convince the patient, it's difficult to convince the doctor to use rubber dam. It's absolutely true, because it's very difficult to convince ourselves to start using rubber dam. Patients, they don't need any kind of convincing. They are ready to accept whatever you are throwing at them. Okay, right. So this is one of the biggest misconceptions, that my patients, they don't agree to all these things. There's nothing like that. I don't talk to any patient. I don't give so much importance to this rubber dam introduction. I just tell them that I'm putting a rubber sheet and this is to prevent saliva from contacting your tooth or the water from going into your mouth. That's it. I don't give any other explanation, and the patient is also not bothered. What is this? What are you going to do? That's normally what we all have a fear, that my patient will become anxious after seeing such things. There's nothing like that. Nobody objects to whatever you are doing. Then about time consumption. I always tell this, that when you are starting with a trip, you are going on a car drive and then you are stopping at a pump and filling petrol. And do you think that is a waste of time? No, filling the fuel is not a waste of time. That 5 minutes that you spend there is going to help you with your journey, right? So absolutely, that is exactly what your rubber dam application also does. What it does is it gives you some time to prepare the patient. And once that preparation is done, it just allows your further journey to be very smooth. That's exactly what we want here. Okay, then it's not at all a part of advanced dentistry anymore. Okay, even from I think it should start right from the time when the student enters 3rd year of dentistry, so that let them start using it and that it becomes a part of their daily dentistry. It's very difficult. Once you establish a technique, it's very difficult to change or adapt to new things. But when you are starting off with something and you feel that you know that this is part of normal dentistry, then it becomes a part of your daily routine itself. It's not a part of advanced dentistry. And it's not at all difficult to master. But of course, there is a learning curve, and that learning curve continues even if you are 10 years practicing into rubber dam dentistry. that learning curve continues. There is always a case where you feel, or where you think, oh, in this case, how am I going to achieve isolation with rubber dam? There are always cases like that. So it's not that if once one fine morning you master the technique of rubber dam and then you start doing it in all cases. No, there is going to be cases where you'll be frustrated with rubber dam, but still you have to have that conviction that I will practice only under rubber dam. Okay, so there is no question of whether to dam or not, just dam it all. Okay, right. So we'll go to the introduction of rubber dam. Without introducing this person, there is no point in talking about rubber dam, because you can see it's almost 150 or 160 odd years since this thing was invented. So it's not a part of new or advanced dentistry. We know that it's almost 160 years now. So this is a typical rubber dam kit, how it looks like. There are many things in this. Probably many of you have already seen all these things, but it may be new to few of you. So probably I'll just point to all these things. This is the rubber dam sheet, or what we call as the dam material. Okay, now this is the rubber dam forceps that you can see here. We'll discuss about this also in detail. Then you have the rubber dam punch, and you have a collection of rubber dam clamps, okay, or retainers, whatever. So these are, you cannot work with a 1 or 2 or 3 or 4 rubber dam clamps. You will see that with time you go on adding more and more rubber dam clamps to your collection. Why? Because each case is different, is challenging, and then you will slowly understand that only 3 or 4 clamps will not help you in all the cases. Of course, we will be using only those 3 or 4 clamps in majority of the cases, but there will be cases where we will need other clamps also. We'll discuss about some of those things as we go ahead. Now you need a dental floss, just because you need to pass the rubber dam sheet in between the teeth. Okay, then you need any water soluble gel, not Vaseline. Vaseline is not water soluble, so you need a water soluble gel. Then you have a template here, then a marker pen, and all these things should be in your kit. Okay, it's not that you don't have a pen and then you go somewhere and borrow a pen. It's not like that. You should have a pen or a marker with you, so that you need it in each and every case that you're going to do. Okay, so you have to have it in mind. Okay, then you need a scissors, and then you need rubber dam frames. These are stainless steel frames. We'll discuss about them later. And this probably many of you know, this is a floss holder. What is the use of this? We'll discuss later. Then you have a roll of Teflon tape, PTFE. Okay, these are all the things that I have in my rubber dam kit. We'll discuss about this. We'll go through all these things as we go ahead. Now the dam material, or the rubber dam sheets, just to give you an idea that these are available in 2 sizes, 5" by 5" and 6" by 6". The 5" by 5" is what you use in pediatric patients, and 6 by 6 is what you use in adult patients. For the cost, for the effectiveness of cost, you can use 5 by 5 for single teeth isolation also. So that gives you, I mean, if the cost is a concern, then 5 by 5 definitely will bring down the cost, because you can use it for single teeth isolation. Okay, just that economy part of using rubber dam I'm taking. Then you have these rubber dam sheets available in various thickness. Now there are thickness starting from thin, medium, heavy, and super heavy. But super heavy and thin, it's very difficult to get. Normally we use medium and heavy. Where you need thick, where you need heavy tissue retraction, you can go ahead with a heavy dam. But most of the other cases, a medium dam will do. Okay, so and medium dam will do, right? So then this is not with many of the brands that you have a dull or a shiny surface. One of the surface is shiny and the other surface is dull. So what the advantage of this is that the shiny surface goes towards the patient's face, and the dull surface faces towards the operator, because the dull surface does not reflect light. Okay, so it's like a matte finish. It doesn't reflect light, so it helps it helps in the vision or the visibility of the operator. So that's why it has two surfaces. But the cheaper ones or many of the economic rubber dam sheets, they do not have a dull surface, and they have shiny surface on both the sides. Okay, I don't know why they could make it dull surface on both the sides, but it is. Now, then for dam material, you have two kinds of dam sheets available. One is a latex dam, that is the normal rubber dam, a rubber sheet, and then you have a non-latex dam. That's meant to, especially meant for those who are allergic to rubber. But I have not come across, very rarely I have come across a patient who is allergic to rubber. Probably that's very less in India, I think. But more importantly, what I use a non-latex dam for cases where the patient is very sensitive to rubber sheets. For example, the stretch of the rubber sheet, the patient may not like the stretch of the rubber sheet. Sometimes the patient may be a little uncomfortable to rubber sheets because they are quite stretchy. So in such cases, I use a non-latex dam because it's very flexible. It's much more flexible compared to latex dam, though the cost is at least 3 or 4 times that of non-latex dam. It's still very handy to have a non-latex sheet with you. Okay, so majority of the time, or 99 or almost 100% of the time, I go ahead with a latex dam. But very rare instances, I have for very rare instances, I have a non-latex dam also with me, right? So that was about rubber dam sheet. Then we have rubber dam frame. So basically there are many kinds of frames, one made of plastic, the other made of metal. So you can use either of them. There are fancy types like foldable frames. I don't have one which folds, but they say when you have a foldable frame, it helps in taking IOPs in between the procedure. But you can do that even without, I mean, even just by removing the frame completely, you can take an IOPA, which I feel is much more comfortable for the patient also. Okay, so basically you can have a plastic or a metal frame, depending on your convenience. I have been using metal frames since the time I'm using rubber dam. So I'm just continuing, and they are there for at least 10 or 12 years with me. It's going good. It does not damage. So it's like a long-term investment, you can say. Okay, so then you have this O-shaped or U-shaped, and majority of the rubber dam frames that we have is U-shaped, which is good enough. Nygaard Osby, this is the round one or the O-shaped one. Not necessarily, I mean, you can go ahead with a simple U-shaped rubber dam frame, right? Now, coming to the heart of rubber dam. This is the most important part of rubber dam. So I always tell my students also, you can go ahead with the economic brands for your frame or the template or such things, or even rubber dam sheet also, you can go ahead with an economic brand. But when it comes to retainers, I always prefer branded ones. Okay, so that's because that is the heart of the rubber dam assembly. Now, if the heart goes bad, if the clamp comes out again and again, or if it breaks once, your effort goes in vain. Okay, so I want the clamp to be the best, because that is what is holding the entire assembly to the tooth. Okay, so right, so just to know the part of the rubber dam clamp, we have a bow. Okay, and then two jaws are there, and these are the two jaws that are going to hold the teeth. I mean, hold the tooth. Okay. Now, if it's a winged clamp, you will have two wings. You can see here there is a lateral wing and there is an anterior wing. The advantage of wing, we'll discuss about it later. Then you have prongs. So you have two jaws on both the sides, and each jaw has two prongs. So totally you have 4 prongs, and prongs are where the clamp is going to contact the tooth, right? So this is a collection of rubber dam clamps. This is a kit of rubber dam clamp. If you are planning, if you are planning to buy, this is a good kit to invest in. This is a wing. You have winged clamps and wingless clamps. They are by Fiesta, Coltin. So it's extremely good ones. to start off with your rubber dam practice. Okay, and this is the one place where I recommend a brand. You can use Fiesta, or you can use Q3D, and even KSK is also good enough. It works in my hand, so I am just recommending those if you are planning to buy a kit. Okay, right. So you can have you can have an assorted kit like this, or maybe I can give you a few recommended clamps also. Either one is okay. At the end of our discussion, probably I'll just give you a collection of clamps that I am using, right? Okay. Now, when it comes to clamp, I told you that there is something called as winged clamp and there is something called as wingless clamp. Now, unfortunately, or by, I don't know, by convention, the wingless clamp has a prefix of W. It should have been the other way, but I don't know how they have named it like that. But wingless clamp is called by a prefix W. Okay. Now, for example, there is a clamp number 8. So number 8 means it's a winged clamp. If it's W8, it means a wingless clamp. Okay, that is what you have to remember when you are ordering clamps. Okay. Now the advantage of winged clamps is that the wing is on the lateral side and on the anterior. So what it does is it retracts the rubber sheet, a little more retraction, maybe 3 millimeters on this side, 3 millimeters on this side, 3 and 3 on the anterior also. So approximately 6 millimeters on the lateral side and 3 millimeters anteriorly. So it gives space for your fingers to work around the tool. That is one advantage that I have felt with a winged clamp. Now, another very big advantage is that if you are starting or you are planning to start using rubber dam from tomorrow, for example, so you want the simplest technique of placing rubber dam that I'll show you at the end of this presentation. So using a winged clamp, you will have the easiest technique of placing a rubber dam. I'll show you that technique later. Okay, so the technique of placing a rubber dam is very easy with winged clamps. Then why do we need wingless clamps? Basically, because this winged clamps, the wings of the clamps may sometimes impinge with the adjacent structures. For example, you are working on a third molar. You are doing an RCT on the third molar, or probably your anchor tooth is third molar. The lateral wings are going to impinge on the external oblique ridge, which if the patient is anesthetized will not realize it later that time, but after the anesthesia wears off, the pain of root canal will not be there, but the pain of the metal impinging on the oblique ridge will be there. So such areas, or example, you are doing it on upper 7. So there will be many times where the coronoid process is going to interfere with the placement of a clamp there, especially with the winged clamp. So these are the areas where we like to use a wingless clamp. Okay, so they are easier to place in areas where there are adjacent structures. That is one thing. And then it's very important that it is used in cases where we are using matrices and retainers. We'll see that in the next slide, where if you see here, see, for example, on the picture on the left, you can see it's a wingless clamp. So if I want to place a wedge here, if I want to place a band here, the wings are not going to interfere because it does not have a wing. But in this case, if you see there are anterior wings, and if suppose what would have happened if there is a anterior wing here, it will interfere with the placement of wedge. So you need to have wingless clamps also. So now, just after showing that slide, I'm showing you this slide where I didn't have the winged clamp. This is a very old picture of mine. So I didn't have a wingless clamp, or probably it had gone for autoclaving, whatever. So I used a winged clamp there, but somehow I could manage with placing the clamp and the wedge. At least 8-year-old picture this is. So this just shows that we can still go ahead with some of the adjustments if we can, but otherwise most of the time we will need proper wingless clamps if we are planning to do restorative procedures, especially proximal surfaces. If it's if it's on the occlusal or a class 1 restoration, winged or wingless doesn't make a difference. But if it's a proximal restoration, it really makes a difference. Okay? So here also you can see this is because this is a second molar, and the placement of the winged clamp was interfering, or I feared that it will impinge the oblique village. So I prefer to go ahead with the wingless clamp here. Okay. So these are simple. And then there is another type of clamp which is called as toothed clamp, or some of the companies call it tiger clamps. Basically, that it has claws. You can see that the jaws has teeth or claws. Okay. So what it does, as the name suggests, or as you can see from the picture, that it increases the grip on the tooth. So they are supposed to have very tight grip on the tooth, especially useful in partially erupted teeth. I'm not a really big fan of this, but it's always useful to have one of the, it's always good to have a toothed clamp, because many times the teeth may not be it may not have a proper contour. Also, in such cases, you can use a tiger clamp or a toothed clamp. Okay. Now, then there is another type of clamp which is called as a gingivally directed clamp. You can see here it's a gingivally directed clamp. You can see that the teeth of the clamps are gingivally directed. The prongs or the jaws are gingivally directed. Again, as from the look itself, you can understand that these are the clamps that are used for partially erupted teeth, or the cases where we need to engage the tooth at the subgingival level. These are called as festooned clamps. So if we need to engage the tooth at the subgingival level, you can use gingivally directed clamp. Again, very useful, because you cannot go ahead with your rubber dam practice if you do not have these festooned clamps with you, or the gingivally directed clamps with you. For example, this is a case where you can see it's a gingivally directed clamp. This is a case where I'm planning to do the bonding of onlay here. So this is a flush gingival margin that you can see here. Now, as soon as I place the clamp and place the rubber dam, the flush gingival margin became supragingival, because the gingiva was retracted. And you can see some amount of liquid dam also placed. I'll talk about liquid dam later. But this is the advantage of using festooned clamps, or the gingivally directed clamps. Now, this is another beautiful case by Dr. Liba, my good friend of mine. You can see here that it's a subgingival margin, and how beautifully this subgingival margin was made supragingival, and the tooth was isolated properly. Again, this was possible because of the festooned clamps. You can see the number of the clamp here. It is 14A, which is a gingivally directed clamp. If you see the set of hygienic clamp which I showed here, you can see this clamp there. Okay, so these are all clamps that are very, very important for your daily dental practice here. Right now, apart from all those, what I was talking about till now was retract, and they were called as retention clamps, or they were used to retain the assembly onto the tooth, as I told you earlier. Now, apart from this retention clamp, there are some other kinds of clamps called as retraction clamps, which the hygienic markets the name as Brinker clamps. Now, what is the advantage of Brinker clamps or the tissue retraction clamp? As the name suggests, they are used to retract the tissue gingiva. Okay, they are not strong enough to retain the assembly to the tooth. Okay, they are not strong enough to retain the assembly to the tooth. They can help you in retracting the tissue. For example, in this case, you can see here, there is almost a subgingival caries here. So the first thing that we did was we isolated we applied the rubber dam sheet. Then we used a Brinker clamp. The number here is B4. So that is a type of Brinker clamp. Now that was used to retract the tissue, the gingival tissue along with the dam. So now you can see that the subgingival margin became supragingival, or the flush gingival margin became supragingival. Now it's very easy for you to go ahead and do the preparation, remove the caries, prepare the tooth, and go ahead with your restoration. Very simple thing to do. Okay, so this wouldn't be possible, and there is no, this is immediate post-op. That is another thing that you have to note. There is no single drop of blood that has come from that region. That is only possible because we respect the tissue, we manage the tissue very delicately, and we did apply only the adequate amount of pressure that is required. Of course, if you are using a retraction clamp, I always prefer giving local anesthesia. Otherwise, I don't normally give local anesthesia for the sake of placement of rubber dam, unless I'm using a brinker clamp or a tissue retraction, right? So apart, that was a kind of clamp. Then you have these double bowed clamps. I'm not a big fan of these. They are especially useful for anteriors. Now, one thing that I always feel is it restricts the movement of your instruments near to the tooth. I really want a really free space to work around the tooth, and these two bows that you can see here, they interfere with my way of working. So I prefer, especially for for anteriors, I always prefer multiple teeth isolation, even for endodontic purpose. The advantage that I get is I can actually see the positioning of the tooth. I can see the inclination of the tooth. I can see the angulation of the tooth, so that I can do the access opening without risking any perforation. If I just isolate a single tooth and use a double bow, very difficult for my aerator to go and do the proper access opening. And then if only single tooth is isolated, again, I cannot judge the angulation or the inclination of the tooth. So that can lead to perforation especially if I am in a big hurry. So I don't want such things to happen. So I normally prefer multiple teeth isolation for upper anteriors, even for endodontic purpose, right? So, okay, now this was about the clamps. Now, how to select the clamp? You can see that there are certain number of clamps which are designated for the tooth, like you have the number 2 and the number 2A for the premolars, or you have the number 7, number 8, number 14 for different kinds of molars. Now, learning the numbers doesn't make much of a difference. All you have to do is have a few collection, and then probably for initial few cases you have to pick them with the numbers, but later on what you will realize is that just by looking at the tooth you will go and select the type of clamp that is best fitted for that tooth. Okay, so anyway, so going ahead, the way we select the clamp is that the 4 prongs should be at the line angle. Okay, the 4 prongs of the clamp should be at the line angle of the tooth. So that is how you select the width of the tooth and the width of the size of the clamp that you are selecting. Okay, so that is as far as the line angle is concerned. Okay, now for example, you can see in this case again, it's not possible, as I said earlier itself, that either you should have many number of clamps, or then you should wait for one clamp to come back after autoclaving. Or in other cases, you can simply go ahead with some kind of regard here. It's not a perfect way of placing a sheet, but since my area of interest does not interfere with the clamp, or my clamp is not interfering with the area of interest that I'm working on, I could simply go ahead by placing this clamp. Still, as I said, it's not theoretically correct, but it still works wonderfully. So I'm just giving you a very clinical perspective of how you can adjust your armamentarium, or how you can adjust your things according to the case, right? So now, placing of the rubber dam clamp, that's also very important. Now, as I said earlier, that I do not give anesthesia for the sake of placement of the clamp. Why? Because I am not going to impinge on the gingiva. I'm not going to cut the gingiva. I'm not going to pierce the gingiva. What I am doing is only retract the gingiva. I'm just going to engage the sulcus. That's all. I'm not going to impinge the gingiva. So engaging the sulcus does not cause any pain, and even if it causes discomfort, it is just for a few seconds, maybe 3 or 5 seconds. Most often the patient may say that it gives some pressure, but that pressure goes off within a few seconds. For the sake of that, we need not give local anesthesia. That's what I'm trying to tell. And if you are giving anesthesia, ensure that your clamp is perfectly placed, because you don't want the patient bleeding after you remove the clamp. Okay, you don't want the gingiva to be, I mean, you don't want the clamp to carry away a piece of gingiva along with it. So again, that is very important, that if you are giving a local anesthesia, ensure that your clamp is in perfect position, it's not injuring the gingiva, right? So the way to place the clamp is to place it just above or below, right? Just apical to the height of contour of the tooth, the area where you have the maximum convexity, just place it apical to the height of contour. And once you place it there, just drag it to position. You don't have to just place it and directly place it on the gingiva. What you can do is just place it apical to the height of contour and slowly drag it so that it goes and stops at the gingival sulcus. Okay, so just place it at this point here and drag, I mean, and just slowly place it in position, so that now the patient is comfortable and it's not going to cause any pain or discomfort, right? So again, just showing you where to place the gingiva, I mean, where to place the clamps. You can see here many times you crowned tooth, especially you have, if you have supragingival margins, you can also protect the crown of the adjacent tooth or the anchor tooth just by placing the clamps below the margins of the crown. Okay, right? So this is exactly where you need to place it. Now these are some commercially available cushioning pads called cushy, which you can use to prevent trauma or prevent damage to the ceramic crowns that are placed. Okay, you don't want the steel, or you don't want the clamp to take away a piece of the ceramic. You don't want it to injure to damage the crown. So in such cases, you can see, you can use these kinds of pads or soft cushies, which can help you in preventing from damage to the crown. But what I normally do is, this is a bridge you can see here. What I normally do is I don't punch that hole, and I just cover the tooth with the rubber dam, and then I place the clamp on top. So it really helps me in preventing trauma to the, I mean, preventing damage to the crowns or ceramic restorations that are there. Okay, so either you can go ahead with those commercially available pads, or you can use some of these techniques, which I use very regularly, because most of the times, at least 1 in 2 or 3 cases, you will see that the adjacent tooth has a crown. So obviously you have to have an idea how to protect the crown. Okay, so that was about the placement of rubber dam, in placement of the clamps. Now you need a punch. I will just rush through this, because this is a universal knowledge, that you know that there is a punch, and the punch has 5 or 6 holes depending on the brand of the holes. Okay, now the largest one is what we use for anchor tooth, which is, the anchor tooth is basically the tooth onto which we are putting the clamp. Okay, when you are doing multiple teeth isolation, for example, from second molar, first molar, and for second premolar. So in that case, second molar is what is the anchor tooth. So the largest hole is for the anchor tooth. Then the smallest hole is for the other molars. Like if it is 7, that is anchor tooth, 6 is the other molar. So we put the second largest for the other molars. Then the third size is for premolars. Then the next size is for incisors, maxillary, anteriors, and lower canines. I'm not confusing you, because you will learn once you start using the punch, you will learn this, and it's not very difficult to learn this. So for upper anteriors and lower canines, you have the second smallest hole, and the smallest hole is for the lower incisors. Okay, so that is normally the way in which we punch for a 5-hole punch, and that is what is normally available now, the 5-hole punch. Okay, right. So that was about punch. Then you have forceps. It's good to have these kinds. I always prefer using these forceps. These are called as Stokes forceps, and ensure that this angle is 90 degree. You don't want that 120-degree angle, because that is not good for placement of rubber dam. I'm telling you this because when you go on, when you try to make a custom kit for rubber dam, you will have to buy forceps from one person, punch from another person, or maybe like that. When you are not buying, if you are not buying an entire kit, so in such cases, you have to ensure that you buy forceps that are at 90-degree, so that you can actually use it for placement of rubber dam clamps. Okay. Okay. So this is a Stokes type, and this is ivory type. Ivory types, they are actually a bit flimsier than the Stokes type, and I prefer using the Stokes type rather than the ivory type. Okay. Now you need to do certain modifications with ivory type, but that you will understand later, because many times this the hole here, the ball kind of thing here, that it's very difficult to take it out from the clamp after you place it. So many times you have to use burr to just reduce the radius or the size of the ball there. Okay. So if you are already facing that issue, just take a burr and then run it around that ball, and then you will see that your this thing fits very well. I mean, you can use it really well. Okay, now you have liquid dam. So many times what happens is, once you place the rubber dam, there will be a small gap between the tooth and the dam sheet. Now this sometimes is very difficult, because whatever hypo or whatever liquid that put in the mouth and put in the tooth, it will flow and go into the mouth, or the saliva will slowly seep in through that space there. So this can be easily prevented or easily avoided by placing liquid dam, which is also called as gingival barrier. So you can place that around those small gaps, and then you can light cure it, and they will stay in place. When you remove the entire assembly, it will come out in a snap. So it doesn't bond there, or it does not interfere with anything else. Okay. So this is one that you can use. So again, you can see that in the developmental groove of the premolars, initial developmental, you can see here. So that is a concavity. The rubber dam sheet does not go into that concavity. So that concavity can very easily be, this is a microscope picture. So that rubber, that gap can very easily be closed using a liquid dam, right? Okay, so these are some of the accessories. I've already discussed some of these with you, but maybe as I go along, I'll discuss more about this. So as of now, I'm just skipping this slide. So this is the floss holder that I was talking about. This is available in Amazon. Okay, so what it does is, it actually helps you to pass the sheet in between the teeth. Now you can do this with both the hands very easily, but many times what happens is, your other hand may be engaged in retracting the tissue, rubber dam sheet. So in such cases, you can ask your assistant to just put one on the rubber dam, or that floss holder, and then you can use the floss holder to floss the to ease the rubber dam sheet in between the two teeth. Okay, this is a very useful, it's a very handy instrument when it comes to, especially when the contacts are very tight, you can use this kind of an instrument. Okay, right. So again, coming ahead with other accessories, you need sometimes you need flowable composites, especially when you see that the clamp is coming out again and again, and you don't have any other clamp which is you don't have a smaller clamp for the tooth. What you can do is just etch the sides wherever the prongs are attached to the tooth. Just etch and directly place 4 balls of flowable composite and cure it. So you can simply remove it. It will come off if by simply just removing it forcefully, it will come off. Otherwise, if you don't remove it, it will help till you remove it. It will help the clamp to remain in place. Then you need a Teflon tape. Also, Teflon tape is very probably one of the most it's the all-rounder in dentistry, I will say, because it's useful in all fields of restorative dentistry and endodontics. Okay. So, for example, you can see that here we are isolating the distal margin of the canine, and then I need to remove a little bit more caries there, and I need to ensure that my margins are caries free. So in spite of doing putting a rubber dam, and using a floss tie. In spite of that, I can still see that I need a little more tissue retraction there. So in such cases, I use a Teflon tape. You can see a Teflon tape here, and I slowly push the Teflon tape into the sulcus. It will mechanically push away the sulcus and expose more of gingiva. Okay, you can see a very interesting case here. This was a case with multi-surface caries. You can see you have a cervical caries and deep cervical caries, and then a proximal caries also, which is extending onto the almost up to the lingual surface, right? Okay, now what I've done here is isolated the tooth completely. Now, in spite of isolation, I mean, this here you can see that there is a retraction. I mean, there is a retention clamp already on the second molar, and that is maintaining the clamp in or the assembly in position. After that, what I'm doing is I'm isolating or I'm retracting the gingival margin of the first molar using a retraction clamp. Okay, this is a retraction clamp. I'm retract so that now I can see that all the margins are exposed, and the subgingival margin has become supragingival. And also you can see the Teflon tape that is placed below the retraction clamp to ensure maximum retraction. You can see the retraction, I mean the Teflon tape here also. So you get maximum retraction and extremely good isolation for this case. So the advantage of doing all these things is that you can get a very beautiful finish or a beautiful continuity between the root surface and the composite. There is no step between the root surface and the composite. That is the beauty. And then you can see immediate post-op also there is very minimal bleeding, because we have tried to minimize the injury happening to the soft tissue, so that the soft tissue healing becomes, I mean, it happens beautifully. Okay, and this is the immediate post-op. This was the restoration area you can see here. And the beauty of this procedure is visible in this 8-month post-op picture. The patient came for a filling here. The one another tooth here you can see again a subgingival caries. Again we went through the same procedure, but you can see the beauty of the restoration that we did 8 months back, how beautifully the gingiva has adapted well to our composite restoration. Okay, that is because of the seamless restoration. There is no bound step between the root surface and the restoration. Of course, these things take a bit of time to develop or to understand and do, but ultimately you will reach this stage. This again is the occlusal view of the 8-month post-operative, right? Okay, so now we'll just see how to punch the holes. You can use a template which comes with the, either it comes with the packet of the rubber dam, or you will have to buy a template separately. GDC and such companies have good templates. You can use either a template or you can use the intraoral guide also. Intraoral guide is a very simple thing, but only thing is that you need an assistant to hold the sheet onto the patient's tooth. Now you can just stretch the tooth and keep like this and put dots or mark the center of the tooth. You have one marking here, one marking here, one marking here. So you can go on putting a marking on the center of the tooth. So what that does is you, after you put the markings, you can just take out and then punch the holes at the corresponding position. What that does is, many times what happens, for example, this is a very common mistake that we always we do, that I am planning to do a restoration on a maxillary first molar, for example. Now, okay, by default, I think, okay, the restoration is going to be on first molar, so I'll put the anchor on second molar, then I'll punch hole till the canine or the lateral incisor, and then I punch holes. After I punch the holes, I see that one of the hole is extra. That was because the patient had already done an orthodontic treatment and one premolar was missing. I missed that. That is, of course, a big mistake from my side, but I missed it somehow. And then I see that I have an extra hole. So to avoid such things, you can use this. And then many times what happened, one of the tooth is buccally placed or there is crowding between the teeth. in such cases, what happens is we have folds like this. Again, my own mistake here. So you can see there is a fold like this in between. That was because the teeth were crowded. So if I had used the intraoral template, which now recently I've started using, so the advantage that I felt is that such mistakes can be avoided. And then suppose you have a case where there is spacing between the teeth. Of course, the best thing is to use the teeth themselves as the template and not use the template that you get with the rubber dam sheets. Okay, so this is one way in which you can help, or one way in which you can prevent the mistakes like this that I'm showing here, right? So these are some guidelines for hole placement, where to put the place hole and such things. Again, I'll just rush through all these things. For example, if you are doing a restoration on incisors or mesial surface of canine, what you have to do is isolate from first premolar to first premolar. Okay, but if you are doing a restoration on the first premolar, then you will have to isolate from second premolar to whatever teeth on the other side. Okay, only the anteriors, if I am planning, I'll do only from premolar to premolar. If it's on molars, I will not take it to the entire opposite side. I'll show you another technique where you can prevent putting holes in all these teeth. What happens when you put holes in all these teeth? You have to place the rubber dam sheet in all those teeth, and it will take more time. So we have a little jugaad for that also, where we save time by doing something else. So what you can, this is basically for incisors, for you can place from premolar to premolar. It's a very simple way, and this is what I do for my anterior endodontic purpose also, so that I have a very clear picture about the angulation or inclination of the teeth. Okay. Now for restorative work on posteriors, technically you have to isolate from the anchor tooth, which is normally one or two teeth behind the tooth which you are going to restore. So you have to start from the anchor tooth to the opposite lateral incisor. That is what technically you have to do. But what you can do is you can isolate a few teeth on the operating side and then use another clamp. Again, it's not, you can say it's a additional clamp. It's not a retention clamp, but same, that's the same clamp that used for retention. So you can place that clamp on the molar on the other side. What it does, it allows space for your hand and the instruments to work. Your mouth mirror may have to come this side. Your rubber dam sheet is really beautifully stretched, so that whatever water that your aerator sprays, it gets collected here. It forms that kind of a concavity which will help you in operating beautifully. Okay, so this is one easy way out. You place only 4 or 5 holes, as many as you require, and then the opposite side you just place a clamp on the opposite side molar. It can help a lot in your procedure. Okay, now again, you can go ahead and simply do these 4 teeth isolation. But many times when you only these 4 teeth isolation, you will have a fold of rubber dam here, which will not help, which will interfere with your wedge placement and things like that. So I normally prefer putting a clamp on the opposite side of the tooth on which I'm working. So basically, for restorative purpose, it's always good to do 3 teeth isolation. Okay, minimum 3 teeth isolation, right? Now for class 5, this was a picture that I've already shown. For class 5 restorations, normally I put a larger hole so that my rubber dam can be stretched more to the cervical region. That's all. If it's a premolar, I will put the molar hole in that, so that my sheet can be pulled more cervically. And this is another very big advantage of non-latex dams here, because they stretch, and it's practically limitlessly they stretch. So you can use it in these cases where you want to really stretch the sheet. Okay, and then in such cases also I prefer using branded or good ones, so that the rubber dam sheets don't tear at the end of the procedure. During the procedure, I don't want that to happen. So use good dam sheets for such cases, especially when cases where you have to stretch the sheet beyond a particular limit. Okay. Now for single teeth isolation, normally single tooth isolation is used for endodontics, and if you really want to learn and using rubber dam, you can start using rubber dam for pit and fissure sealants and small class 1 restorations, especially those which are not very close to the marginal ridge. Because when it comes close to the marginal ridge, it's always good to isolate the adjacent tooth also. So if you really want to start learning rubber dam, if you have the kit, from tomorrow just start putting it in single teeth restorative procedures before you start with endodontics. Because endodontics, again, you have to use long files, you have to get used to the rubber dam sheet first. Otherwise, using the files will be very difficult. Okay? Right. Now another now coming to a specialized technique of using rubber dam, there is something called as split dam. So this can be used in many scenarios. Like in one, this is taken from the internet. So this picture you can see particular here, this tooth is almost non-existent and still wants to go ahead with the restorative process. So in such cases, what you can do is just cut through the 3 holes and put the clamp on one hole and additional anchorage. This is called as Vijit. You put the Vijit on the other side, and then you have a space in between. This space can be closed, or the fluid movement can be stopped by placing your flowable, your liquid dam, right? So this is one simple technique called split dam technique. It's again very simple, useful technique. Like I wanted to restore this facial surface of the canine, but this is a joint crown, so I couldn't pass the rubber dam sheets through this. So I just cut the entire thing, and then you can see how I have inverted the margins inside. So once you invert the margins, you don't really have to isolate it with the your liquid dam. Okay, so this again is a very useful technique, because we see bridges almost in every other patient that we work on. So you have to have an idea how to isolate or use rubber dam in such patients. So again, split dam technique shown here. Very simple way of this is it's almost like a root stump. So in such cases, we can use split dam technique. Now this is a dam inversion. Why we do dam inversion? Because we don't want the fluid to seep through. So we just tuck inside we tuck the margins inside, so that whatever fluid comes inside, it gets collected here and does not flow through. So if the margin of the dam was like this, this is called everted margin. If there is an everted margin, whatever gingival fluid comes or the saliva comes, it will flow or seep through and fall on the tooth. Okay, that's why we do dam inversion. Now, how to do dam inversion, I'll show you in the video demo. We have floss tie. Why do we use floss tie? I've already showed you floss tie. Not the technique of floss tie, which probably you will have to depend on a YouTube video, because it's very difficult to demonstrate here. So the advantage of floss tie is that it makes a flush gingival margin into a supragingival margin. See, this is a very practical case where you can see there is a large caries to be filled, and the margins are subgingival. So immediately after I put a rubber dam, I put a floss tie, and now the margins are supragingival. Now I can go ahead with further caries excavation. This is not the immediate next step. After this, we did further caries excavation and pulp protection. All such things were done, and then the proper restoration happened. Okay, so this is why we need a floss tie. Again, a floss tie where I am planning to do a bonding on bonding of overlay. You can see that this is almost a subgingival margin that I am trying to isolate using a floss tie. Okay, now very simple case of floss tie you can see here. Sorry. Just a second. Yeah. You can see there is it's a grossly decayed caries, and the margins are subgingival. Now what I have done is I have cauterized the margins and made the margins, exposed the margins. Now the next step I'm going to do is isolate the tooth. Again, for endodontic purpose, I prefer isolating the entire anterior sextant so that I get a good idea about the angulation of the tooth. Now I am trying to push the margins of the rubber dam subgingivally. Now that's not happening here. You can see, in spite of all the struggle, I've not edited the video especially because I wanted to show you the amount of struggle that we have while placing a proper rubber dam sheet. So what I have done is I have placed the floss tie now, and now after placing the floss tie, I am trying to somehow place the floss tie subgingivally so that I can take the margin of, I can take the rubber dam sheet also along with me. You can see how I could take the rubber dam sheet along with me, and I'm tightening the floss. Now you can see how the floss has carried the rubber dam sheet subgingivally. You can see the area has become completely blood filled, but that's the only way out because we have done gingivectomy to expose the margins. Yeah. Okay. Now we have cut away the excess of the floss. Now it's just a matter of cleaning up the area and making it presentable for a picture, right? So the entire thing, then you can see that the margins here are inverted. Now this is a very simple way in which you just invert the margin, just cut away that region. Now you can see the almost entire margin is supragingival here, and it is ready to go for a restorative procedure. This is a post-endodontic restorative procedure that I am planning on this. Okay, right. So again, this you can see inverted margins all around so that this area is completely isolated. Now, what is one? I mean, once if you have used the rubber dam, you will see that there is something awkward here because the frame is not like this. The U is not facing upwards. Instead, the U is facing downwards. The frame is why I have placed it facing downwards is because I wanted the dam to engage the frame on top so that I get really good retraction of the lips here. You can see the impression of the lips here. And another important thing that you note here is that this is a clampless isolation. I mean, I don't remember why I did that, but you can see that there it is a clampless isolation. I have engaged the rubber dam clamp just using a piece of rubber dam itself. I mean, I have engaged the rubber dam sheet just using a piece of rubber dam sheet itself. Okay, so just to show you some cases there. Right now, there are cases where we need gingival modifications. Like in this case, I have showed you a case where I needed a gingival modification. Just to show another case where we are going ahead with the endodontic treatment of this tooth. You have seen many of these cases online also. Many cases you see how a subgingival margin becomes supragingival. So you can see here how simply with the cautery it's just a matter of 3 or 4 minutes. It doesn't take much of a time. So just using a cautery, I remove that piece of gingiva that has grown into the tooth. Now once that is removed, I'll just go to the next slide. It looks like this. Okay, entire that gingival margin has been removed. Now once that is removed, I do the caries removal also before I isolate the tooth with rubber dam. So this is after the caries removal, and now I have put the rubber dam sheet here, and then you can see the floss tie so that I push it subgingivally. Now after I have done that, this is a temporary pre-endodontic buildup. I'll be removing this after the endodontic procedure with a proper core buildup where we are planning to go ahead with an onlay. So that's why the contacts need not be so proper. Just for the sake of pre-endodontic buildup, we are doing this. Okay, so this is a normal workflow of how we change a very grossly carious tooth into a workable tooth for endodontic purpose, right? Now, see, basically for rubber dam application, you need to do all these things. Select the anchor tooth, right? Now, anesthesia is again, it's it's not for all cases. If you are planning to do procedure and if that procedure demands anesthesia, you can go ahead with the local anesthesia. It all depends on your comfort, your patient's comfort. So I will not recommend one thing or the other thing. So you can do as per your requirement. Then select the retainers. So with the time you will simply select it automatically, but initial days you can select it looking at the size of the tooth and looking at the number of the clamp you can select. So basically once how you select is you place the clamp on the tooth, see that it is contacting, all the 4 prongs are contacting properly, and just pull it with your finger. If it's not coming out, it means it is stable and it will retain there. If it's coming out or you feel that it is unstable, remove and use a smaller clamp for that tooth. Okay. There are cases where we use small premolar clamps for some small molars also. So everything is, it's not like a single rule. It just you can use it as per your requirement. Secure the clamps with floss. Again, that's the ideal thing to do, but I really don't think many of us practice that. But if you really want to practice safest dentistry, then you have to tie the clamp with a floss, which I'll show you in the coming slides. Okay. Now, this is very important. I get these questions here. How to pass the floss through, how to pass the rubber dam through the contacts, especially in tight contacts. What I really feel is the simplest way is just before you place the rubber dam sheet, just pass a floss through all the contacts 3 or 4 times. Just pass it through all the contacts. Once you do that, that itself will ease the contact so that your rubber dam sheet goes much easily. If you just try to push the rubber dam sheet through a contact without doing the flossing, it's really difficult for many times, especially in patients with tight contacts. In such cases, always in all cases, don't see whether it's a tight contact or a loose contact. Unless you have an open contact, you just take a floss and pass it through all the contacts. That will really help you to put the dam through these contacts in the next step. Okay? So check contact, floss, and lubricate. If you want, you can lubricate with a water soluble gel like KY jelly, but be very cautious because a little extra will make your hands slip and then you cannot even stretch the rubber dam sheet. You will have to wash the sheet and wash your gloves and then again redo the whole thing. So the lubrication has to be very carefully done. You don't want it to be very slippery. Okay. Now you have to punch the hole. Again, lubrication, it's you have to be very careful when you lubricate. Okay. Now it's the next step is to apply the dam and retainer on the anchor tooth. Now this I'll show you in this demo, and this is the simplest technique by which you can place a single tooth. You can do isolation of single tooth. Okay. This is a number 7 molar clamp. This was my favorite until I lost it because it didn't break. So this was my favorite for all endodontic procedures, a number 7 molar clamp. This is a winged clamp again. Okay, now let's see how it works. The first step is to select the clamp. Okay, now I'm selecting the clamp. Before I select the clamp, just see that the way I am holding the clamp. This is for placement on a maxillary molar. Okay, so that is the way I hold the clamp. You can hold it as per your wish, but this is the way I hold it so that I can actually see and carry the entire assembly into the patient's mouth. Okay, so that's my grip for maxillary teeth, and for mandibular teeth, I hold it normally. Okay, we'll see that. Right. So this is the view from the top that I am showing you. The patient is not anesthetized. You can see it's not patient, so it's not anesthetized. Okay, so you can see how I am holding the clamp and the forceps. Okay, now the next step is I slowly place the clamp just below the height of contour and then just drag it. That's all. I am not going and impinging the entire gingiva. I am not holding it like this. I just hold it like this and then slowly drag it towards and slowly push it towards the towards gingival sulcus. That's all. Okay, so, and especially the non-festooned ones, they do not even engage the sulcus also. So it's very comfortable. Only the gingivally directed ones engage the gingival sulcus. So even this is even more comfortable to use, right? So that is how I selected. Now what I didn't show is you have to just put in a finger and just try to pull it out. If it is not coming and if it is not unstable, just that is the clamp for your tooth that is selected. So just remember this number 7 molar clamp for, it's like an universal molar clamp. It's intended for upper molars, but it is like for all the teeth. Okay. Now the next step is to prepare the dam sheet. This is for single tooth isolation for endodontic purpose. What I'm doing here is I'm just pulling all the sides, 4 sides. I'm pulling the dam on 4 sides, not very tightly. It's very loose here. You can see how loose here. And then I just take the punch. I didn't have to do the rest of the 2 holes, but it's okay. I'm taking the largest hole. And remember, this is for single tooth isolation. I put a single hole there. Then partially overlapping that hole, I am putting another hole. So now the hole is like 8. Okay, you have 2 holes. This is what I normally do. But if required, you can put a 3rd hole. It looks like a clover shape now. You can see there are 3 holes. Okay, so this, I don't do this normally. If I'm using a heavy dam, probably I will use this. If not, I will just use it. Okay, now the next step of what I'm doing here is engaging the lateral wings. You can see I'm engaging the lateral wings, ensuring that the anterior wings are not engaged. Okay, only the lateral wings go below the dam. Okay, now see, what I'm doing here is disengaging the rest of the edges, and I'm just maintaining the superior most spikes here. I'll be removing the other 2 also. Okay. So now what you can see here is it's like my assistant is holding the dam from the top, and my other part is like a flag. It is free to move. So I'm just taking it comfortably to the patient's mouth, inside the patient's mouth. The advantage of removing it from the other spikes is that does not stretch the dam. So it's easy for me to carry the dam inside the patient's mouth. Okay, now I have placed, and this is an important stage where you have to ensure that you have isolated the tooth that you are going to treat. Especially for if suppose you are doing an intentional RCT on a tooth, ensure, and that tooth will most probably will not have a caries. So ensure that you are not doing it on the wrong tooth. That is one mistake that can happen. Okay. Now what I'm doing is, after I place the clamp, I'm just pulling all the edges and I'm putting it, I have engaged it on all the 6 spikes. Okay, so this is the stage 1 completed. The entire assembly is in place. As now you can see that clamp is what is holding the entire thing. Okay, now I am using a sharp instrument. I normally prefer a sharp instrument. Many people prefer blunt instrument. It's up to you. So what I have done here is, now I am pushing the sharp instrument between the dam sheet and the clamp, and this disengaging it. Now what happens is, the dam sheet disengages from the lateral wing and goes and attaches or adapts to the tooth. Now you get a proper contour, proper closure at that lingual surface. Same thing I am doing on the buccal surface, but just ensure that the cheeks are pulled by you, because that sharp thing will go and prick the cheek, and the patient is not anesthetized. It can be painful. Okay, just ensure that does not prick the cheek. You have to just pull it and then disengage that also. Now that also goes below the clamp and attaches or adapts, approximates with the tooth. Now this completes the placement of rubber dam for a single tooth isolation. Okay. This, I'm just ensuring that nothing is engaged anywhere else and it is adapted well. I just depress it so that whatever, if it is engaged, it will go and adapt well, right? Now this case it doesn't require, but I'm just giving you a demo so that you know when or how to use a liquid dam. So just placing a liquid dam here, you can see if at all there is a gap. 99% of the time you don't see any of gaps here, especially if you follow this technique. But just in case you have a gap or you see saliva seeping through one of these gaps, you can just place the rubber, the liquid dam, and yeah, that's it. You can just cure it, and that will be done, right? I'll go ahead with the next slide. Okay. So that was about single tooth isolation. Now about multiple teeth isolation. Maybe you can see how I do of it's not normal. You can see how floss is tied to the clamp. I mean, there is no hard and fast rule that you have to tie it like this or like that, but this is a very simple technique that I use if at all I need to tie. So what I'm doing is, whenever you do this, just ensure it's not a single tie that is happening. You have to tie the entire bow of the clamp. This is what is important. Okay, you have to ensure that the entire bow of the clamp is tied. Okay, now once that is tied, you can push it back. Now you are bringing it out to the other hole. Now the entire clamp is secured. Even if it breaks when you place the clamp, no part of it is going to slip into the patient's mouth. Okay, right. So I'll just go to the next slide. Right. Now we'll try and place it on the premolar. Trying to place it on the premolar. Good. So if it's staying well, you can, if you want, you can push it cervical. You can push it more apically, but if it's stable and if it stays well, we'll go ahead with the next step. The next step is to pass contact through all the contacts. Unless it's an open contact like this, you don't have to pass the contact. Okay. So just ensure that all the contacts are clean and smooth. Right. This is how I keep a KY jelly with me, so that it's very easy to dispense in very small quantity. The entire tube, if you use, you will not have a control of the amount that comes. Okay. Now the next step is to use a template and mark the points. Now you can mark the points with a permanent marker or a gel pen, which is easy to use. Okay, or ball pens are not that easy to use in such cases. Now once that is done, I punch the holes. I'll just rush through this slide because you all know how to punch the hole. The largest hole is for the anchor tooth. Okay, now so in this case, the anchor tooth is a premolar, so we will not use the largest hole, but we'll use a molar hole probably, because you don't require the largest hole. That is for a molar anchor tooth. Okay. Right. So it all depends upon your level of comfort, the stretchability of your dam sheet, etc. That you will understand only after you start using a couple of times. Okay. Now, once that is done, once all these things are engaged, I just missed recording this part of the video. That what I have done here is I have placed the clamp on the premolar. Now I am stretching the dam, taking it over the bow and placing it on the tooth, stretching the dam and taking it over the bow and placing on the tooth. That was missed in the video, but after that, what I do is I just pull it inside. Okay, how you see how I pulled it from top of premolar, because I don't want to isolate the second premolar. That is not my interest now. Okay. Now what I do is I just try to pass it through all the contacts. I roughly pass it through all the contacts. Why I roughly pass it through? Because I want to ensure that I have not missed any hole. Okay. So I just roughly pass it through all the contacts and take it to the opposite anchor tooth. You can see that I'm not bothered about passing it through the contacts at present, right? Yeah. So once I've done this, and all this is done single-handedly, you don't actually need an assistant to help you for all this. But if you have, well and good. Okay, now my other hand is engaging the forceps onto the clamp. Yeah. So now the other clamp is ready. I just push it down. So that's it. So that was about, you can see it has come out. I just want you to see the entire struggle. So I didn't edit the picture. See, edit the video. Right. So now that is done. Now what I'll do is I'll engage the frame. Once you engage the frame, everything will be stable, and then you can slowly pass the contacts. You slowly pass the rubber dam through the contact. This is how a frame will look after you place. The U will be open upwards. Okay. Now, if it's a very open contact, you can simply use your fingers to pass it through. But if it's a tight contact, you will have to use a floss to pass it through. Okay. Now, I always prefer manipulating the sheet with a very, very sharp instrument. What I feel is, if you are careful, it will, you can very precisely manipulate the area that you want to manipulate. If you are using a very blunt, broad instrument, you will not be able to manipulate the area precisely, and then that can actually lead to a tear. Now, this is what you can see is an inverted margin. See, this is an inverted margin, and you can see that the saliva is already seeping through. What you can do is you can ask your assistant to blow the air directed apically, and then what you can do is, using your sharp instrument again, just pull it with one finger and then use the sharp instrument to direct the free margins. It's as simple as this. Okay. Everything gets done in a few seconds time, maybe in 30 seconds or maximum in 1 minute. You can do that inversion of the dam in very easily, and ensure that the same thing happens lingually also. Many times this inversion may not stay properly. In such cases, you will have to do a floss tie and then invert or do the traction with the floss. This is probably the last step here, is we had put a floss tie inside, and that has to be taken out, especially of the first dam the first clamp which we placed, the floss is inside, and we just take it out. Otherwise, that will act as a passageway for your saliva. Now you can tie these ends onto the frame. Yeah, you can just tie it to the ends of that floss to the frame. Right. Okay, so I'll just move ahead. Okay, very quick single. So this you can see again, single tooth isolation very quickly. It's for a retreatment. You can see the sinus here. We have removed the crown already. Now we are going ahead with the retreatment. See, ensuring that it's stable. Just in case it was not stable, I'll use a small blob, small drop of flowable composite to ensure that the clamp does not slip out. Okay, now you can see how I just stretched it over the bow, and then I'm just pulling it so that only single tooth is isolated. Slightly fast forwarded, but even then it just takes 1 minute to do isolation. Just ensuring that it's stable and good to go. Right. So this again is that number 14A clamp. Useful, especially in such cases. I don't use it very regularly, but it's useful in such cases where you need. See, this is all what has to be done. No flowable liquid dam, nothing is required here. So that's all from my side. So I wish you all a happy and stress-free dentistry, and I hope that rubber dam helps you in really doing that stress-free dentistry. Thank you. It's quite a long session. I was allotted till 10 o'clock, but I think that extra half an hour will be more than
Sir,
helpful.
but we enjoyed the session, sir. So we enjoyed the session, sir. So we are waiting for questions from the chat box. We are ready to take questions. So there's Dr. Jason. Thank you. Thank you, Vijit bhai. Vijit bhai.
I'm
Okay.
still happy that 69 people are still there.
Yes, sir. So we're waiting for questions from the chat box. So I think we can wrap up for the day. So once again, thank you, sir.
Yeah.
Thank you, sir, for being with Online Dentistry. So here we come to the end of the session. So stay tuned till second Wednesday of the next month for another punching session. Thank you, sir. Have a great day.
Yeah, thank you very much. Bye.